X-linked disease conditions that are quite relatively rare. And the aim of this study was to look at the postoperative outcomes, especially the mid to long-term outcomes in all patients undergoing total elbow replacements. And our primary outcome measures were preoperative blood loss, postoperative complications, revision rates, and length of hospital stay. The secondary outcome measures selected a priori were mean elbow range of motion, looking at the flexion, extension range of motion, and the pronation, supination range of motion. We also looked at the mean functional outcome scores, either using the Mayo Elbow Performance Score or other scoring systems that were reported in the published studies. And finally, we looked at the mean visual analog pain scale scores. So for our materials and methods, we adhere to the preferred reporting items for systematic reviews and meta-analysis PRISMA guidelines. And the databases that were searched were PubMed, Medline, Embase, and the Cochrane Register. We searched for all studies from inception of these databases up until October 26, 2022. And quality appraisal or risk of bias analysis for each study was performed using the methodological index for non-randomized studies, which is the MINOS criteria. The inclusion criteria that were selected were human studies in patients with hemophilia A and B. So we excluded any cadaveric study. We included studies that had a minimum mean postoperative follow-up of 1 year. So all studies that had a mean postoperative follow-up less than 1 year were excluded. This was to enable us to report adequately on mid to long-term outcomes. We also included studies where a unilateral total elbow replacement surgery was performed in the same sitting. If the patient had surgery for another joint in the ipsilateral upper limb, such study was excluded because we felt if you have multiple surgeries of the same extremity, it could affect your functional outcome scores and it could bias. We will not be able to assess whether the problem is from the elbow or from the hand or from the shoulder exactly. Patients who underwent polytrauma surgery were also excluded. So this is the PRISMA flow chart for this study. We identified a total of 129 studies from the databases. From Medline, we identified 15 studies, Embase 24, and PubMed 90. From the Cochrane database, we found 9 studies. After excluding duplicates, we were able to identify 23 studies that we retrieved the full text articles to analyze if they met the inclusion criteria. We were not able to retrieve the full text article of 1 study. For the other 22 studies, we included 7 studies that met the eligibility criteria. 4 studies were excluded because they included a wrong population. 3 were excluded because of wrong study design. 2 were excluded because the minimum follow-up was less than 1 year. 2 other studies were excluded because of wrong treatments, not meeting the inclusion criteria. 1 study was a conference abstract, and this was excluded. And 2 studies were non-English full text articles, they were excluded. And 1 was a letter to the editor. So looking at our results, we grouped in patient characteristics. We had a mean postoperative follow-up of 8.1 years with a standard deviation of 2.5 years from all the pooled studies. The pooled mean age of the patients was 43.2 years, with a standard deviation of 7.6 years. In the 7 included studies, there were a total of 51 total elbow replacements surgeries performed in 38 patients. And the most common prosthesis was a Conrad-Murray prosthesis, which is a cemented linked and semi-constrained prosthesis. And this was utilized in about half of the patients included in the study.
Also looking at the patient demographics, we looked at, because hemophilia, most patients with hemophilia A and B, commencement of adequate HIV screening and discovery of highly active antiretroviral therapy. The problem of hepatitis A and B and HIV infection was quite significant, especially in patients who received blood transfusion in the 80s and early 90s. So for the patients included in this systematic review, 47% of the patients had HIV infection, 23% of them had hepatitis B virus infection, 40% of them had hepatitis C virus infection, and 10% of patients had combined hepatitis C virus and HIV infection. This is important because, as we are aware, these viral conditions can cause immunosuppression and increase risk of postoperative complications and postoperative infection. Looking at the primary outcome measures, as mentioned earlier, the pooled postoperative complication and revision rates were 49% and 29% respectively. So it means about half of the patients had one form of postoperative complication or the other, which is quite high. 40% of the revisions that were done for these patients were for periprosthetic joint infection, and 1/3 of these revisions were for aseptic loosening. Surgery-related postoperative mortality was 3.9%. What this means is that if a patient dies within this 10-year period postoperatively, and if it's related to a medical condition, possibly HIV infection and all that, they were not included as part of the analysis for surgery-related mortality. So if we compare this, so coming back here, we have 50%, roughly 50% postoperative complication and 29% revision rates. If we compare these results with the study under systematic review by Chu et al., published in the Bone and Joint Journal, we can see that for their own study, they looked at rheumatoid arthritis. So we looked at hemophilia, they looked at rheumatoid arthritis. And they had 38 studies with about 2,000 patients. And if we look at the complication rates, they had a complication rate of 25%. So this is roughly half of the complication rates observed for patients with hemophilia. And they also had an implant failure rate of 16%, which is still lower than that observed for total elbow replacement for patients with hemophilia. If you look at the secondary outcome measures from our study, the mean preoperative Mayo elbow performance score was 43. So for the Mayo elbow performance score, the higher the score, then the better. It means the elbow function is better compared to patients who have lower scores. So the mean score preoperatively was 43 with a standard deviation of 20, while the mean postoperative Mayo elbow performance score was 89 with a standard deviation of 6. Looking at the visual analog pain scale score, the mean VAS preoperatively was 7.2. And as we are aware, a higher VAS score between 1 and 10. So a higher VAS score means a higher pain score according to the patient. For the postoperative VAS, it dropped to 2.0 with a standard deviation of 1.4. If you look at the elbow range of motion, we looked at the flexion arc and also the pronation supination, which gives you the rotation arc. The mean preoperative flexion arc was 54 degrees, standard deviation of 15 degrees, while the mean postoperative flexion arc was 91 degrees with a standard deviation of 10. If we go to the rotation arc, which gives you an idea of the amount of pronation supination of the forearm, the mean preoperative rotation arc was 86, and it was 135 degrees postoperatively. Looking at evidence from the literature, this study also looking at long-term follow-up, similar to what we did, reported by Bako et al. And published in the Journal of Bone and Joint Surgery. They looked at total elbow arthroplasty for distal humeral fractures. And they found that if you come down to the Mayo elbow performance score, they found similar high scores of 90.5 postoperatively. If we come to the study for rheumatoid arthritis I mentioned earlier, they also found that for the mean postoperative measure elbow performance score, they had 89.3. So it appears that for postoperative functional outcome scores, TER gives similar results to patients who had rheumatoid arthritis and distal humerus fractures. So it means for hemophilia, outcomes were good. However, if you look at the postoperative complications and revision rates, it was quite high compared to these other studies that were performed for rheumatoid arthritis and for distal humerus fracture. In the discussion of the detailed paper that I've written down, even if you look at other conditions, like if you are performing TR for traumatic elbow conditions, if you're performing TR for primary osteoarthritis, we also found that there were lower complication and revision rates compared to our hemophilia cohorts. So what are the strengths and limitations of this systematic review? One of the strengths was that we adhered to a structured format using the PRISMA guidelines. We reported on mid to long-term outcomes as far as 10 years postoperatively. And the results from this study will be important when we're counseling our patients before surgery. Maybe the patient wants to find out, okay, you're offering me different surgical options, conservative management, elbow replacement, and all the whole mixed bag. So what are the complication rates for this surgery? What was the evidence for this and all that? So it can be useful for counseling our patients. Looking at the limitations of this study, according to the Minors criteria, most of the studies identified for this systematic review were of moderate quality evidence. There was no randomized control trial identified. And most of this, in fact, all the studies were level 4 evidence. If you use the Oxford evidence-based medicine classification system. And also the pooled sample size for this systematic review was relatively small, which is not surprising considering the fact that hemophilic arthropathy of the elbow is relatively uncommon, and total elbow replacement of the elbow is still in the early phases, especially for this disease condition. How relevant is this review to clinical practice? So, as I mentioned earlier, it gives us a good evidence summary when counseling our patients and offering them surgical treatment options. Key messages are the complication rates from total elbow replacement for hemophilia is quite high, especially that attributable to infection. And we believe this is due to the relatively high co-infection with HIV and hepatitis. If we have patients who are going to undergo total elbow replacement for hemophilic arthropathy of the elbow, it would be nice if preoperatively they are optimized and they are on heart therapy. And finally, pragmatic randomized control trials, which should be multi-center ideally, are needed to provide us with higher quality evidence. Thank you. I don't know if you have any comments or any questions.